behalf of my co-authors, I'd like to thank the ASCO committee for giving us the opportunity to present the Javelin Bladder 100 phase 3 results. The study is entitled Maintenance Avelumab plus Best Supportive Care versus Best Supportive Care Alone after platinum-based first-line chemotherapy in advanced urothelial cancer. Next slide, please. These are my disclosures. Next slide. Bladder cancer or urothelial cancer is the sixth most common cancer in the US and responsible for 200,000 deaths globally. First-line chemotherapy is standard of care, and this is platinum-based. Most patients respond, but unfortunately progression-free survival and overall survival are short because resistance to platinum-based therapy occurs. Immune checkpoint inhibitors such as avelumab are a standard second-line treatment after failure of platinum-based first-line therapy. The issue with second-line therapy, even second-line immune checkpoint inhibitors, is only a minority of patients get second-line therapy, and because the disease is aggressive, outcomes are short. Therefore, the Javelin Bladder 100 study gives immune checkpoint inhibitors directly sequenced with chemotherapy instead of waiting for the cancer to return. So it's essentially a first-line maintenance approach for patients with metastatic urothelial cancer who have not progressed on first-line chemotherapy. Next slide, please. So the patient population, as I've mentioned, first-line metastatic urothelial cancer, patients who have not progressed on first-line chemotherapy. The chemotherapy can be between 4 and 6 cycles and cisplatin or carboplatin-based, so a broad spectrum of chemotherapy. Patient needs to start the study within 10 weeks of completion of the chemotherapy and a 1-to-1 randomization of avelumab versus best supportive care. 2 co-primary endpoints, overall survival in the all-comer population and the PD-L1 positive population. PD-L1 positivity was defined by the SP263 test. 51% of patients were PD-L1 positive. Next slide, please. The overall survival in the avelumab arm was 21 months, and the best supportive care arm was 14 months. And you can see from here the curves go apart early and stay apart, and that generates a hazard ratio of 0.69, which was statistically significant. Next slide, please. Subgroup analysis broadly favoured the avelumab arm. I draw your attention to the PD-L1 positive population with a hazard ratio of 0.56. This was also a co-primary endpoint, but you can see the treatment works across broad subgroups of patients, different chemotherapy regime, different response to chemotherapy, and visceral metastasis. Next slide, please. The progression-free survival also favoured avelumab with a hazard ratio of 0.62. This supports the overall survival data, and you can see a nice plateau there associated with avelumab. It's also important to say the avelumab in this study was well tolerated, and this is very much in line with what we've seen for previous immune checkpoint inhibitors in urothelial cancer. The final slide, please. So in conclusion, this study met its primary endpoint, showing significantly longer overall survival with avelumab maintenance therapy in both the overall population and the PD-L1 population, which were the 2 co-primary endpoints. Overall survival was also longer in a series of pre-specified subgroups, different chemotherapy regimes, different responses to chemotherapy, visceral metastasis. The safety profile of avelumab is in line with what we've seen with other immune checkpoint inhibitors in this setting, which is obviously encouraging and good news. So overall, avelumab first-line maintenance therapy in patients whose disease has not progressed with platinum-based induction chemotherapy is a new first-line standard of care for advanced urothelial cancer. Thank you very much for your attention. I'd be very happy to answer questions.